Good afternoon. I'm Wendy Goldberg. I'm the Tri-Faith Initiative Executive Director. It's a pleasure to be here with all of you today and to invite our special guest, Dr. Ali Khan, who is the chair of our board, as well as the Dean of Public Health, for what I'm certain will be an informative conversation around 1 year into a pandemic. We've learned a lot. When I was thinking about something I might start with today, the word courage really resonated with me. I think it's taken us a lot of courage to get through this year. And so I'd like to just read a little piece from David White about courage. Courage is the measure of our heartfelt participation with life, with one another, with community, a work, a future. To be courageous is not necessarily to go anywhere or do anything, except to make conscious those things we already feel deeply, and then to live through the unending vulnerabilities of those consequences. To be courageous is to set our feelings deeply in the body and in the world, to live up to and into the necessities of relationships that often exist with things we find we already care deeply about, with a person, a future, a possibility in society, with an unknown that begs us on and always has us begged upon us. To be courageous is to stay close to the way we are made. I hope that this is a courageous conversation today, that we not only think about what you're going to be able to do once you get the vaccine, because we all have that in the back of our mind, but also what that's going to mean to the collective impact for us to stay strong until we reach those indicators that we have for the safety for all. And so I think it would be interesting for us. I've invited Kareem Kayati, who is the president of the American Muslim Institute, as well as a member of the Tri-Faith Board, to start out to give us a little bit of framing. Kareem, are you here?
I'm here, Wendy.
Great. Kareem, tell us what the last month has been like for you.
Thanks, Wendy, first for having me here, and at least, kind of help share my experience the last 30 days or so. It's been a little bit over 30 days, to be honest. And everyone, I'm glad to be alive and be on this Zoom meeting. I think this is I feel privileged to being able to live in a country like, fortunately for us, that we have the level of care and support, which is probably not the same for everybody worldwide, but we're fortunate. So, but yeah, I think everyone, I consider myself a healthy, very vigilant. I've been doing everything right, based on, the recommendation of, our public health leaders and stuff like that. But unfortunately, it looks like I let my guard down sometime in the last 6 weeks or so, and contracted this COVID thing. So anyway, been tough. I had about 2.5 weeks where I was fighting this looks like flu thing, and didn't want to go away. Very typical what you hear in the news. Fever, body aches, everything kind of not comfortable, and got to a point about I think Valentine Eve where I knew I was in trouble. My things start kind of becoming a little bit weirder, and that's where I checked myself in a hospital and ER, and within hours I was in ICU under a lot of oxygen support. Things happened very quick. So everybody be careful, but don't think this is like a progression that happens over, it really kind of takes you by surprise. And so anyway, I think I was, again, as I mentioned, I was lucky. I was in ICU for about 8 days. Great level of medical and people support. The nurses, I think, are amazing, and all their, the team, the respiratory. I think when we talk about nurses, hopefully we mean everybody with the doctors, right? I think there's a lot of people even the cooking stuff and cleaning stuff. I mean, I think all these people were amazing. And I feel more spoiled because Wendy knows this, but my wife is an RN, and for 2 weeks, she took 2 weeks off, and I felt like I have an extra privilege there. So yeah, I mean, it's been tough experience, but I think with luck and a lot of support and sure prayers, I was able to, I think, make it out. Still in recovery. I think from what I understand, it's going to take a little bit of time. It's not something that, it's just happened overnight. So yeah, I mean, I think I feel lucky, humbled, spoiled, grateful, and I'm going to continue to fight this thing. But the one thing I want to leave everybody with is this is big. Don't let your guards down. Even if you get the vaccine, just continue to be vigilant because it's really very strong for anybody. So that's it.
Thank you for sharing with us. I thought that was kind of an important place setter for us to remember, and perhaps also to hold in our hearts that I imagine that many of you who are on the call today have either yourself been impacted or someone that you love has. And we're holding all of you in our thoughts and prayers, and together we're going to get past this. I remember a year ago on a call nearly to the day, Dr. Khan told us to isolate the virus, but not people. And I think Tri-Faith and our community of Omaha has been very forward and in our intention to do that. And so I hope we all feel the strength of the community that we see in front of us, 80 strong on this call already today. I know most of you came because Dr. Khan is a worthy thought leader, and what a privilege that we have that you're sharing your time with us again. You were with us on a call on May 28th of 2020. And I'm wondering if the first thing you could perhaps tell us, Dr. Khan, is how has your job changed since then? You're muted.
Thank you, Wendy, and thank you everybody who've joined us for this call this afternoon. My job is, and I think for probably true for everybody on this call and across the US and worldwide, has dramatically changed over the last year. As you know, I'm Dean of the College of Public Health. It's a privilege here to serve in that role, and we have been at the forefront of helping to protect our communities against COVID and devising the best science to do so, all the way from how do you reuse N95 respirators. So when there was this crunch on personal protective equipment, to how do you address vaccine confidence now, and what communities do we need to reach out to in different ways to make sure that they get vaccinated. We help train all of the people in Nebraska and in other places on how to do contact tracing. We have strike teams that go out and do this. We currently have students deployed across the state helping with various response related issues. So very different from where we were a year ago, Wendy.
Thank you. I think it's important to celebrate what's working. So I know we're hearing a lot about what's not working. Can you tell us today what is working?
Absolutely, glad to. So I actually have a couple of slides, if I may.
Yep. You have permission to share.
And what I want to talk, so for those who don't know, my background is our Tri-Faith Center. And I'm hoping to welcome all of you on this call in person or more virtually to our activities from the Tri-Faith. So it shouldn't surprise you that the theme I want to talk about today, given the privilege I have to serve on the board of Tri-Faith, is hope. So I want to talk a little bit about hope and how things have dramatically changed in some ways from March of last year. One thing I did not anticipate in March of last year was the devastation this disease would have in our communities worldwide. And tragically, over 100 million cases worldwide and 2.5 million deaths. And even more tragic than that, is the disproportionate number of cases and deaths in the US. So the US only represents 4% of the global population, and yet we have 25% of all cases and 20% of all deaths. And I'll be very honest with you, I never would have predicted that at the beginning of a year ago from now. But as I said, what I want to talk about is hope and how vaccines are part of the puzzle to that path of hope. And can't talk about hope without recognizing all the frontline heroes that during this pandemic, from our delivery workers to our public health workers, clearly our healthcare workers, but so many other people who we depend on every day to keep our communities running. So I always like to start with a couple of quick slides to frame where we are now. So the good news, again, trying to keep with a positive theme, is a dramatic decline in cases in the United States and actually worldwide since the beginning of the year. And this is called an epidemic curve. So it's a date on the bottom, number of cases. And you'll see that cases have dramatically dropped in the United States, but this is a good reminder from this curve that we still have not dropped below our second peak in the summer. So cases are still quite high in the United States, although fortunately not as high as they were back in the back at the turn of the year. I realize, thanks to Zoom, we no longer have a Nebraska audience. We have a regional, national audience for our Tri-Faith calls, but here's a Nebraska-specific slide to show the impact in Nebraska. And this is actually a good mirror of what's going on in the United States. So yes, unfortunately, too many deaths in this state, which would have been tempered potentially with additional measures. But currently, this state has also seen a market decline in cases and the number of people who are positive. And I'm on this right side is deaths. And I want to show this to make the point about this concern about who's going to get vaccinated when. And if you vaccinate people 65 years and older, you pretty much will cover somewhere between 80 to 85% all deaths that occur within our community. So that's good news for the current approach to vaccination, which is one of the main reasons for the hope that I have about this disease moving forward. This is a snapshot. This is available to every state in the union, depending on where you're zooming in from COVID Act Now. And even though cases are markedly lower in Nebraska, there's still too many cases in Nebraska currently. So let's talk about hope. And I love this picture on the right of my slide to me about a community church blessing COVID-19 vaccines in Houston. And I think this is just a nice little sort of a compilation of faith and hope coming together with science and how that comes together to help enrich our communities. Now, before I give you a couple of quick slides on vaccines, I always want to remind people that there's numerous countries that have 0 cases and 0 deaths today without vaccine. So unfortunately, whereas many countries in the East tested, traced, and controlled their disease, China, New Zealand, Australia, Singapore, et cetera, that was not a choice made in the West that delayed, debated, and unfortunately divided the population, where sometimes we were fighting ourselves instead of fighting the virus. And that has unfortunately led to tragic increase in deaths in many countries. But in those countries, we already have the experience that if we layer all of our public health measures together, and now we have this wonderful option of vaccine, we really can get disease down. So I will always talk about layering public health measures to try to decrease disease in our communities and get back to a better normal. I say better normal because all sorts of things about the old normal that I didn't like, right? Social inequity, et cetera, et cetera. So let's talk about vaccines. I have 3 or 4 slides on vaccines, and I'll try to, and I'm doing this to address what I saw were the questions that people had. So hopefully I can address most of those questions in these slides. So this is a great source of hope, right? About 100 vaccines currently in some level of testing worldwide for COVID, including 6 that have been approved for full use. I always show the 4 abandoned slides because abandoned vaccines, because people often say, well, anything that's out there gets approved. And the answer is no. There's stuff, including stuff by major manufacturers like Merck, that never got approved because they weren't good vaccines. So just to reinforce that there's good science behind this on what gets approved. And one of the questions I often get is, well, this was done so fast, weren't you cutting corners? And the truth is actually no corners were cut. There were still the traditional, in our lingo, phase 1, phase 2, phase 3 trials. This is what you would do for any biologic product. That all happened. However, in this case, we were lucky that we already had the technology to make this happen. We had unlimited money to make this happen. The Food and Drug Administration was a partner in making this happen. Research data was collected electronically instead of on paper forms, and there was no problem finding volunteers for these studies. So thanks to all of this, we were able to condense a multi-year timeline into a 1-year timeline to have drugs available for Americans. So no corners were cut whatsoever. And if anything, these vaccines have been under greater scrutiny than any other biologic product. I have never in my 30-year public health career seen companies actually publish their protocols on who's going into these studies, right? I've never seen the FDA Facebook Live their meetings. So you saw exactly what the discussion is. Because while these vaccines are safe, and they work, the most critical element is trust. And if you don't trust them, then who cares if they are safe or if they don't work? So to make sure that there was trust there was amazing transparency in this process. I can get back to this little cartoon if people want to, but basically it says there's multiple ways to go from virus to your immune response. And we have 3 different ways to do it with vaccines. And some are chop up the virus into various pieces. Some is put pieces of the virus in another virus to help you make your own immune response. And the final is the mRNA process, which is we just bypass all that and say, here's a little instruction manual, make the right stuff. Let your own body make the right stuff. So currently there are 3 licensed vaccines in the United States. The first 2 that were licensed were with this messenger RNA technology. Again, not new. There was data on this for many years, including a flu vaccine that was about to be licensed using this technology. They're both very effective. They're very safe and have been approved for use worldwide. And for all the fun data that people talk about, efficacy and effectiveness, I just like to show real world data. So this is the drop in nursing home deaths with the vaccine. So this is real world data, people surviving because they got vaccinated. So excellent news. These vaccines work to save lives. Both of them, actually all 3 of them work to save lives. And there's lots of data to support that, almost 100% to save lives. This addresses some of the concerns I often get about these mRNA vaccines. There's no live virus in it. The technology is new, but we knew how to use it. It's been rigorously tested. I've shown that. It does not get into your body and change your DNA. And it does not lead to infertility. There's no microchip with this vaccine. And although I would love if there was the luciferase gene, so this is a gene that lets you glow, there is no gene that makes you glow if you take this virus, if you take this vaccine. So just that's some of the questions that we get with the vaccine. The third vaccine that just got approved last week and was deployed starting Monday and getting into people's arms this week is the Johnson & Johnson vaccine. This uses a different technology. This is the same technology we use, for example, for Ebola vaccines. So this takes a snippet of the virus, puts it into a different type of virus that's very mild for us, and then we develop the right immune response to it. There's lots of news about, well, is this really as effective and has the two mRNA vaccines? And what I like to people to focus on is that about 4 to 6 weeks out, nobody dies, nobody gets hospitalized. This is a good vaccine, right? And this is a vaccine, if you can get it, if it's the first vaccine available to you, please get it. It's also 1 dose as opposed to the other vaccines, which are 2 doses. So a lot of advantages to the Johnson & Johnson vaccine. And sticking with my hope theme, there's going to be a big jump in vaccine supply. So I know there's probably potentially people on this call who are like, when is it my turn? Well, let me tell you, your turn is coming up before the end of May, because thanks to a recent announcement by President Biden, oh, wait, this is wrong. Oh yeah, forget this. Instead of the end of March, this should be the end of May, because President Biden just bought a whole bunch of brand new Johnson & Johnson vaccine to be made by Merck. So the promise is by the end of May, there will be more than enough vaccine for anybody in America who wants it, okay? This is March 1st. So within 60 days, anybody in America who wants vaccine, there will be more than enough vaccine to get them vaccinated. And this is even before 2 new vaccines that are in the pipeline come on board. We expect that the AstraZeneca vaccine will likely, it's already been approved in multiple countries, likely maybe approved in the US by end of March. We've already pre-bought a bunch of that. So in April, potentially there may be even AstraZeneca vaccine available to Americans. So it's good news on top of good news where vaccines are concerned, thanks to the work of the previous administration to make the vaccine and the work of the current administration to scale it up and get enough to everybody. And what we're seeing right now in the US, over 2 million people are getting vaccinated a day, with the goal by the end of the month to get to 3 million people every day getting vaccinated. So good news on top of good news where vaccine is concerned. But let me leave you with 2-3 final thoughts. The first thought is that, going back to my earlier comment about let's use all of the public health measures available to us, we know that if we abandon all of the other public health measures and just depend on vaccination, we will see more people infected and who die. So we still all need to collectively layer on all of these protections to prevent as many infections as possible until everybody gets vaccinated. The other, the sort of, if you want to call it the fly in the ointment, are these variants. Well, unfortunately, because we never controlled the disease, the virus had the opportunity to mutate and create copies of itself that are much more infectious and some potentially more deadly, and others that look like they will not respond to vaccine or our current drugs as well as the original virus that has been circulating. So this is a quick little schematic of all the variants, the 3 major variants that we worry about. There's actually 2 more in the US, so I should say there's actually 5 variants we're currently worried about, and where they are in the US. So the concern is that, like in Europe, these variants may take over and we may see a new increase in cases in the United States. So it's very problematic that there are states in the United States that do not have a mask mandate, and that Texas, which is still red here, has mask required, I think yesterday or today, I think tomorrow, Friday is lifting its mask mandate. So it'll be the largest state in the union to lift its mask mandate. And there's no reason to believe that science works different in some states compared to other states. And I'm hoping that Governor Abbott made a calculated decision that they will vaccinate enough people faster than variants, that there won't be more cases or deaths. But again, many question whether that's a good choice, and just leave in mask mandates and other protections until you really have guaranteed you have sufficient people vaccinated and the variants under control. But let me end with 2 pieces of, again, the hope theme. Let's look at some of the bright sides of this crisis. So the first is the vaccine, how fast scientists responded. But I don't want to I always want to recognize the selfless dedication of the nurses, doctors, other healthcare workers who really risk their lives to save others. And Kareem gave a great example of that. And what about the selfless dedication of everybody who was labeled essential, right? Truck drivers, grocery stockers, farm workers. I really love the fact that maybe it took the pandemic to help us realize who really is essential in our communities, right? To help us do everything we do every day. And hopefully our lifestyle has changed to practice better hygiene. And finally, let me just leave you this, and this is from my perspective as a member of Tri-Faith, and the pleasure of being a member of Tri-Faith for 5 years now, which is hope. And I like to spell hope with a U. So we spend a lot of time talking about COVID super spreaders for those of you who listen to me or read my articles. But how about becoming hope super spreaders, right? And what a great role for all of you on the call to do that and help people understand how they can be healthier, safer. And at the end of the day, since this is Tri-Faith, how do we celebrate our differences in faith and integrate faith into our daily lives for better lives? So let me just stop there, and thank you very much for giving me the time to present these handful of slides. All right, Wendy, I'll turn it over to you on how you'd like to proceed.
All right. Well, there's lots of questions in the chat. We'll get to some of those as right away, and then we'll come back to a few more of my questions. Thank you. That was a lot of information to take in. Let's start with related to the supply. How about the distribution? There seems to be quite a bit of complications about that.
There were quite a bit of complications around distribution, especially at the start of the year for various reasons, holiday season, understanding what's going on. But currently, over 70% of vaccines that are allocated to states are distributed within a week. And I've seen those numbers go up to 75 to 82%. So states are actually, give credit where credit is due. States are doing a really good job from when the vaccine arrives in their state to putting it into people's arm. We've also addressed all sorts of issues around, in the past, vaccine would get wasted because you have to give it in a certain amount of time. That seems to have been taken care of also. So states are doing a great job. And if anything, we have examples, California, for example, where they've had to shut down vaccination sites because the issue is supply, not demand anymore. So states have been doing a great job, and kudos to all the volunteers that have been helping improve the operations of many of these facilities that are giving vaccinations, including Tri-Faith. And many of you on this call, I think, have been helping out at Coles and other facilities and Medical Relief Corps, et cetera, that have been helping get vaccine out. So it's still mainly a supply issue right now, Wendy. It's not a delivery issue.
Thank you. The next question here is about how long we think this, just in general, once you've gotten the vaccine, you're talking about layering and continued behavior changes, but what advice do you have for people once they've been vaccinated about the protections, and where do the variants play into those decisions?
So I've been vaccinated, and anybody who's seen me recently knows I'm religious about wearing my mask and social distancing. However, I have been a little bit more lenient, I guess, in telling people that once they're vaccinated, they can visit their grandparents and parents and others who they would not have otherwise visited before. I would have told them, maybe not. Now I'm more along the lines of, no, we don't want to socially isolate people. If they've been vaccinated and you've been vaccinated, yes, please still wear your mask, try to social distance as much as possible, maybe leave the hugging off for a little while, but do interact with people more. And we will see CDC release additional guidelines to say, okay, what else? For example, we're no longer telling people they need to quarantine if they're exposed if they've been vaccinated. So slowly we'll continue to lift these measures as cases go down in the community, but until it's a clear evidence that cases are continuing to go down in our communities, we need to be careful. And that's why I showed you that I'm data driven. So I showed you the data showing we have stalled in the US. So we are no longer going down, and we've stalled at a level that we thought was crazy in the summer. So if everybody remembers the summer, I know it was a long time ago, people were panicking on how many cases we were seeing in the summer. Well, that's how many cases we're seeing now. Right. So it's still premature. It's premature to declare victory. Let's continue to get vaccinated. Let's continue to drive disease down in our communities.
So on that, we put together suggestions for faith-based organizations in terms of reopening. And those suggestions stated that until controlled moderate community transmission was under 26 cases per million in the population per day in our community, that we should not reopen. And as of yesterday, whether we're looking over people or tests over tests, which is another confusing thing, we're somewhere between 626 and 792 cases in Douglas County. So
that's a lot of cases still.
It's still a lot of cases. So I know we're all anxious to reopen even our faith, our houses of worship. And in some cases, I'm hearing some mandates from some of the movements to open doors more quickly. What's your advice on that protocol?
So my advice is that more and more people are getting vaccinated, especially those who have been vaccinated. We can maybe open up with low occupancy. I mean, again, my advice is separate from the current directed health measures in the state. So again, I know everybody is not from Nebraska, but if you're on Nebraska on this Zoom, pretty much the governor has declared this is a green zone. So already there's no mask mandate and there's no occupancy limits on anything anymore. I think if you wanted to have a convention of 100,000 people, you're welcome to do so tomorrow in the state. So my advice obviously is a little counter to that. So I would say that faith-based organizations where they can guarantee where they know more and more people are being vaccinated, they can consider maybe coming back at low occupancies. And some faith-based organizations have done that successfully. I think we sure have learned a lot about our health and safety protocols and how to improve our health and safety protocols without getting people infected. So if we refine our health and safety protocols, and in terms of what we've learned, for example, Major League Baseball, et cetera, et cetera, et cetera, et cetera, I think we can potentially think about how to allow some more organizations to meet in person with a handful of people.
And if we're talking about the inequities related to the virus and those who have not had access or who have fear or hesitation to get the vaccine, how do you suggest that we as advocates are thinking about our own personal behaviors, our organizational behaviors in response to those who don't yet have access to the vaccine or who are resistant to consider even getting the vaccine because of past perhaps abuse related to medical science, et cetera, in their history?
So so Wendy, you asked me 3 questions at one time.
I know.
So you asked me a supply question, a vaccine. So all right, let's do. So equity cuts across various issues in this disease, right? And so this virus exploits biologic weaknesses, right? So if you're a male, if you're elderly, and if you're obese, you're not going to do well with this disease. But it also exploits sociological and societal weaknesses, right? And what we have seen is, unfortunately, a disproportionate number of people of color who have gotten sick and died of this disease, right? And that's true for so many other diseases, but it was definitely true for this. And so we need to ensure, given what we saw with disease, as we vaccinate people, that we try to be more equitable with vaccination. That has not been true to date. Some of that is a function of who we decided to vaccinate. So we decided to vaccinate all healthcare workers and assorted people around healthcare workers first. And so that led to a significant amount of inequity. And then we still have issues of, I believe, half of states don't even report race and ethnicity on people vaccinated. So we need to address vaccination and make sure that vaccination is equitable. And there's a lot of federal efforts to ensure that happening. And I see state level efforts also to ensure that you deal with equity. And that means transportation, access, not just via cell phone, but not just via internet, but cell phone. Potentially, it means extended hours, 9 to 5, what a weird time for vaccine clinics. I know some are past that, but weekends and evenings off. And maybe it means mobile clinics in people's communities where somebody shows up with an ice cream truck and instead of ice cream, it's vaccine, right? Actually, that would work well because vaccine needs to be refrigerated. So maybe that is a good use for ice cream trucks, is to hear that little lovely little ding dong and you go, oh, it's a vaccination time. So we need to address those inequities, and we need to think about how do we message to communities that are less likely to get vaccinated. And I like the term vaccine confidence as opposed to vaccine hesitancy. So how do we improve vaccine confidence within our communities? Currently, there are 3 communities. So the good news is there's only about 20% of people left in the United States who say they will not get vaccinated unless it's under no conditions or unless it's mandatory. So that's fabulous news, right? That we've gotten that down from about 1/3 to about 20%. Of that 20%, the 3 major groups are white Republicans, rural people, and there's probably an overlap between those 2 and Black Americans, right? So we need to think about how do we message to these 3 groups that have significant who don't have sufficient vaccine confidence to improve their confidence and find the right messengers for them. So that's the vaccine. So that takes care of how do we improve confidence, and then how do we make sure we supply more vaccine to people who previously have been overrepresented in getting infected. The last piece of that 3rd question, I think, Wendy, is around vaccine passports. And so what happens is you could potentially set up, again, yet another inequity. If people most likely to get vaccinated happen to be of a certain race or economic class, then they're the ones with the vaccine passport, and everybody else doesn't have a vaccine passport, which allows them access to do additional things. But how can you supplement a vaccine passport with actually a disease passport, which is if you've been infected, then why can't you also get a pass? If we can figure out what is the right antibody level to say, you know what, you were infected, so you also get your pass to do activities. So I think that may be one way to address that inequity, but the science hasn't gotten us there yet to say, how do we do the same thing potentially with an antibody test that says, yep, you're just as good as if you've been vaccinated. Next 3 months, you can do anything somebody who's been vaccinated has done.
Interesting. So one of the questions is along those lines. Is there a protocol for how long you need to wait after you've received a vaccine if you've had COVID?
So initially the thinking was you should wait 90 days. And the reason for that thinking was that if you look at the data from the mRNA studies, it didn't look like there was any benefit for vaccination in that time frame. And probably there was no benefit because you were protected because you just had the disease. Currently, the CDC recommendations are that unless you're actively infected, so yes, you need to get over your illness, just go ahead and get vaccinated because it gets too confusing otherwise. So they're just recommending people go ahead and get vaccinated who've previously been infected. I can tell you from all of the data I see that people who've previously been infected, 1 dose is probably more than enough for them.
Okay. There are a couple questions here about the raising back to the concerns about vaccination in general, causing autoimmune disorders, or just what are the other, and then certainly the Archdiocese's suggestion in New Orleans yesterday around pushing back to some but not all of the vaccinations. What if you're going to do a breakdown of the kinds of concerns that you're hearing and perhaps talking points that we might use to counter those naysayers or conspiracy theorists, what toolkit can you give all of us as ambassadors for improving vaccine confidence?
Yes, and you are all hope ambassadors. One of the good news, pieces of good news when we look at vaccine confidence is if you know somebody who's been vaccinated, you're more likely to get vaccinated yourself. So the best thing you can do as a vaccine ambassador is the moment it's your turn, please get vaccinated, because that sends a message to people who may not have been likely to get vaccinated to say, well, you know what, Jim got vaccinated or Julie got vaccinated, I should go ahead and get vaccinated. It establishes the norm. So that's the first thing you can do is the moment it's your turn comes up, please get vaccinated. The first vaccine that's available to you, you are establishing the norm. And then that's what everybody does. So when we look at concerns around vaccination, they fall into various categories of disinformation or misinformation. So the first thing I like to tell people is there's probably been no product that has been scrutinized as much as these vaccines. There are actually over 3 or 4 systems that are looking at everybody who's vaccinated and what their side effect profile looks like. Right, so there's the routine CDC systems, the FDA systems that are in place, and there's now yet even a brand new system called vSafe. So for those of you who've already been vaccinated, I get a text once a week asking me, Ali, how are you doing since you've been vaccinated? So you just sign up for vSafe the moment you're vaccinated. So to reassure people that nothing has had this amount of scrutiny, and if there ever is a concern that comes up, it will be found early and addressed right away. So there's no evidence of people dying from this vaccine. There's no evidence of autoimmune disorders from this disease. The only thing we have seen, and we need to be honest about it, your arm's gonna hurt. It's a vaccine, right? And the most serious effect that we have seen is these anaphylactic reactions. So these are people for unknown reasons, they'll get a severe allergic reaction. Nobody's died from it, right? Everybody's done just fine from those. This is why you get monitored for 15 minutes. And once we now have enough data, it's less than 2.5 cases per million. Right. So it's a rare, very rare thing that happens, but we're being honest. And the reason we know these rare things is because of these great systems that allow us to see these rare things. There's no evidence that you get infertile from this vaccine. And I always like to remind people that if the disease doesn't cause it, the vaccine isn't going to cause it, right? Because the vaccine in some way, shape, or version is a minor version of the disease. So the disease isn't causing an infertility epidemic worldwide. So the vaccine isn't going to cause an infertility epidemic worldwide. There is no microchip in the vaccine. They're just not small enough at this point, but so, no, to put it in the vaccine. The mRNA vaccine does not change your DNA. It can't actually even get into the right part of your cell to change your DNA. It's just a quick little piece of message that tells your body make this, and then it's broken down. That's all mRNA is. And then the final concern is this new concern raised by the Archdiocese of New Orleans, and I believe the Bishop's Congregation also raised it and that's specifically about Johnson & Johnson vaccine. And I do want to state that this is counter to what we've heard from the Vatican itself, that has been promoting everybody get vaccinated. So I always like to go back to the Vatican statement about the moral imperative in this disease is to get vaccinated. But there are concerns by some people that in the 1970s, a cell line was started with aborted cells that is still used in scientific research. That is so 50 years ago. In no way, shape, or form associated in any way with aborted cells, right? It's just a standard cell line out there. And so that's why I believe the New Orleans Archdiocese suggested people not get Johnson & Johnson. My suggestion to you is to get the first vaccine you can get when it's your turn. Save a life. That's the primary imperative. Save a life.
So in this same thread, are you hearing any further discussion around rewarding people or requiring people to take a vaccine, and how are you seeing that addressed in different sectors?
So currently the demand outpaces the supply. So there's been no reason to mandate anybody get vaccinated. There's more people who want to get vaccinated than there's vaccine. We will see how that transitions as the vaccine itself is no longer emergency use authorization, but becomes a licensed product, which then makes it easier for companies and others to say, yes, you must get this vaccine. And there's already some discussions in some industries to mandate the vaccine. But again, that's sort of in the discussion phase. I don't think I've seen anybody say you must get vaccinated in an organization or a group yet, Wendy. But again, others on this call may know if they've actually seen somebody actually mandate you must get vaccine. Heck, we don't even mandate flu vaccine, and we know that saves lives.
We probably shouldn't compare it to the flu. That got us in some trouble.
Yes, this is 15 times more deadly than the flu.
So a question here from Aubrey: faith organizations are facing pressure to open because schools are open. How do we respond to that thinking?
I respond to it by thinking about what puts people at risk. And children, we know, are at a different risk profile than adults. We also know who's likely to die compared to who's not likely to die if they get this disease. So first you need to think about what is the true risk of the population you're talking about, of transmission and of illness and of severe illness and of death. And then you need to think about what are the health and safety protocols you have in place to protect individuals. And then based on that calculus, you decide what you're going to do for your group. So obviously what you would do for kids from K to 5, I would say, is different than what I would do for kids from 9 to 12, based on what I know about disease transmission dynamics. And that's both schools and that's both school kids. But they're based on age. I'm making a distinction, let alone on a faith-based organization and what they're deciding to do based on what their population looks like and who's vaccinated, not vaccinated, how big the venue is, et cetera, et cetera. Right. So if you say if I'm gonna bring back 20 people into an auditorium of 1,000, I'm going to give you a different opinion if you say I'm going to bring back 25 people in an auditorium for 10 with closed doors and windows.
Right. A follow-up question from previous related to that is, are children going to get vaccinated?
Yes, they will get vaccinated. So the work is currently being done. The studies are currently being done to vaccinate children. So of course, you're not going to vaccinate them until you have sufficient data. And they may well, coming into the fall, there may be sufficient data to start vaccinating maybe high school and middle school kids, and then maybe into the next year we'll have additional data on younger age groups. You just want to make sure you're doing it safely before you vaccinate them, especially since you know that their risk of death is low. And not that they're not at risk of getting disease or getting a severe COVID or getting this severe illness called multi-inflammatory syndrome of children. So they're not immune. Let me be very clear, because some people have claimed kids are immune. They're not immune. But you want to make sure, as we did with adults, that anything we give them is safe.
Thank you. Can we turn a little bit more to testing now? Availability, how important will it be? Other questions are, how will it impact our understanding of herd immunity, et cetera? How will it be used?
So testing is used a couple of different ways. Let's start with the last piece of that, which is herd immunity. So at a population level, every week, the state and multiple states look at, for example, blood donation data and see, based on how many people are giving blood, how many have antibodies, to give you a sense of how many people are potentially protected within the community. And now that vaccination is ramping up, there'll likely be community-based surveys to answer that same question. So that's one way testing is used. The other way testing is used is the traditional way, is when somebody thinks they're sick and they're not sure if it's COVID. And that there's actually right now, there's more than adequate testing in our community to do that. It's free, and the timelines have become so short that you can get results back in the same day or definitely within 24 to 48 hours. So the old days of waiting a week to find out that you have COVID are long gone. And to add to that, we now have bringing in place brand new tests that give you immediate results at home or right there at the doctor's office. So the testing landscape is dramatically changed from what people may remember back in the early spring when there just wasn't enough tests.
Thank you. We've had a few questions to widen the scope a little bit globally. So can you tell us about vaccination availability globally? And Ann Naylor's question was specific to Africa or South America.
So vaccine availability globally is not good, right? So globally, there's about been 250 to 300 million doses globally, and I think they're vaccinating at 6 million a day globally. And a lot of those numbers are the US and Europe, right? So I believe there's still, what, 60 to 80 countries that don't have a single dose of vaccine that's been delivered to them. So the global situation is not very good. That said, there is a global financing group called COVAX to provide free vaccine to select countries, and that's already started to give supply vaccine, limited amounts, obviously, to Ghana, for example. And the US recently decided to join that consortium and is now the biggest donor of that consortium. So there will be more vaccine available globally. So that's part of the puzzle of the financing. The other part is the supply issue, right? Everybody has the same supply problems, and those are getting fixed, right? So now Merck, for example, has said that they're going to make the Johnson & Johnson vaccine. Sanofi, which is a gigantic vaccine producer, has said they're also going to start making one of the approved vaccines. And India, which is one of the largest manufacturers of biologic materials, they just had some great data that came out at the Bharat Serum Institute of one of the vaccines that they've been working on, that they've said they're going to, be making 1 billion doses every couple of months or something like that. So the news on the supply side is really good. Unfortunately, it's still a supply issue. Nusrat, I think you said something about, yes, there is the Chinese vaccines. Yes, China's heavily marketing their vaccine in Asia and trying to use it for diplomacy purposes. And Europe is also looking at the Sputnik V vaccine from the Russians to see if that would also be available. So again, things are very slow vaccinating countries besides those in the US and Europe, but things are looking up for an improving supply situation that will hopefully help meet the demand in these other countries.
And then some questions around the need for booster or thoughts or updates on the wet market regulations and public health.
So Wendy, you keep giving me like 3 questions.
I'm just reading the questions. They're coming in bulk.
So,
and we have 6 minutes left.
Okay, so what was the first thing? Wet markets.
Boosters,
yes. Because of the variants, some of the vaccine manufacturers have already made booster shots, and those are undergoing drug trials. Hopefully, those drug trials will not be as large as the 25 to 30,000 previous drug trials. So there may well be booster vaccines if these variants are what we called is vaccine escape variants. If the current vaccine doesn't work, yes, you're going to need a booster, and we'll know more about that within the next 3 to 6 months. Wet markets, there's a lot of work going on by WHO to think about how do you address disease transmission in wet markets so that we don't see this happening again. So wet markets, the only type of food I know comes from Kroger, nice plastic wrapped. That's not true in many parts of the world where you like point at the animal and they kill it right there and they hand it to you. Which is a great way to get viruses passed on to you. So there is efforts to think about how do you maintain cultural humility for countries that take that approach while protecting them.
Thank you. We've had quite a few questions around pregnancy and vaccination, and then the coverage of that vaccination.
The American College of Obstetrics and Gynecology has said to get vaccinated because there is evidence of increased risk in pregnant women from this disease to themselves and to their fetus. So that is the scientific advice from the official source that pregnant women should get vaccinated.
All right. What's our next public health risk? I mean, I feel like 2020 and 2021 has taught us that we don't know what's the next, oh my goodness, are you kidding me? So what should we be mindful of?
Aren't you supposed to end with hope as opposed
That's
to?
not my last question.
Okay, that better not be your last question. Okay, so as a public health practitioner, I know you don't want to hear this from me, but this was not the big one, right? The big one we worry about in public health every day is the next influenza pandemic, which is what we saw in 1918, right? Where nobody in the worldwide would have any level of immunity to a brand new influenza virus. So that remains the biggest threat worldwide, and that's the one I worry about. But given the factors that lead to these emerging infectious diseases, we should not be surprised if we see another Zika virus, for example, that spreads out there, or another virus from this coronavirus family that spreads. So that would be the threats from infectious disease threats. And then there's all sorts of other public health threats that continue to be threats for us in our communities. Chronic diseases, obesity, addiction are continued public health threats that we need to deal with, hopefully with the equity lens. Okay.
Thank you.
Last question, Wendy.
Last question. You are a thought leader nationally. You are so busy. You're the chair of the Tri-Faith Initiative. Why is that so important to you? And what about that has surprised you this year?
So
in my spirit of three questions in one.
Your spirit of three questions. Thank you. I don't think
it's Tri-Faith.
I don't think three questions, Tri-Faith. I don't think it should surprise anybody that a public health practitioner would be part and passionate about Tri-Faith, because if you think, and all of you on this call, when you think about public health and you think about social justice and equity, and celebrating life and everything it takes to be healthy, isn't that what Tri-Faith is? I mean, it's a foundation of Tri-Faith, is that celebration of our differences to improve all of our condition, social justice, and nothing surprised me about Tri-Faith. Did it surprise me that Tri-Faith was going to decide to work in underrepresented communities to see how they can bring different faith communities together to address the need of that community? No, that didn't surprise me. That's what I would have expected that Tri-Faith would do. Would it surprise me that Tri-Faith would be reaching out not just outside of Omaha to other communities that have issues? Nope, that's what I would have expected from Tri-Faith. Would it surprise me that people from Tri-Faith would independently say we want to volunteer our time and energy to get people vaccinated in our communities because we think that's important? Sorry, Wendy, didn't surprise me about Tri-Faith. That's what I would have expected from Tri-Faith. So nothing has surprised me about the people in Tri-Faith, the Commons congregations, the work of the congregations. It's God's work, and no, it doesn't surprise me.
May we all be able to continue together to do the work. Thank you so much for your time and for your service. Thank you all for showing up here today.
Thank you, everybody.
Mask. Get the vaccine as soon as you can.
Absolutely. Anyone you can get as soon as it's your turn.